Hello, everyone. Everybody can hear me okay? Excellent. Hello and welcome back to the Monday evening session of the Hospital Medicine Conference. My name is Maria Burnett and I'm one of the co-directors of the conference this year. We have 4 great talks scheduled for this session. I have the honor of introducing tonight's speakers. As before, please type your questions into the chat and I will read them as time allows at the end of the talk. Or feel free to unmute yourself at the end and ask the questions yourselves. To start us off this evening, we have Dr. Elly joining us to speak about the management of acute pain in patients with opiate use disorder. Dr. Elly is an assistant professor in the Department of Medicine at the University of Vermont, where she works as a hospitalist. She pursued medical school and a master's in public health at the University of Washington. Dr. Reiser went on to complete her internal medicine residency at the University of Vermont in 2020. Dr. Reiser has an interest in harm reduction practices and improving health outcomes for people with substance use disorder. Welcome, Dr. Reiser.
Thank you so much, Dr. Burnett. I appreciate the introduction. Can everybody hear me? I'll presume you can, unless I hear otherwise. So I'm happy to be talking to you today about managing acute pain in your patients who have opioid use disorder, which admittedly is a tricky subject, but I hope I can give you a framework to use in your day-to-day practice. Oh, I'm having some trouble advancing here. There we go. So my objectives for this talk are first to describe some common misconceptions about managing acute pain in people who have opioid use disorder, and to identify some approaches to treating acute pain, particularly in patients taking medications for opioid use disorder. And I'm going to spend most of my time talking about buprenorphine because it's a common medication we see in hospitalized patients, and it has a unique pharmacology that needs to be considered when you're trying to provide analgesia for your patients. So there are only 3 FDA approved medications for the treatment of opioid use disorder. I also refer to this set of medications as MOUD. Some people also use the term MAT, or medication assisted treatment, but this implies that these medications are sort of an adjunct to some other primary treatment, and they really should be viewed as a gold standard for treating opioid use disorder because of their efficacy and their benefits in terms of decreasing mortality. So I prefer the term MOUD, and I'll be using that in this talk. So first, there's methadone. It's been around since the early 70s. It's a full agonist. It has a weak affinity for the mu opioid receptor. There's buprenorphine that's been available for opioid use disorder since the early 2000s and requires a DEA-X waiver, or also called a Data 2000 waiver to prescribe for opioid use disorder. And it has a favorable safety profile that I will get into shortly because it is a partial agonist and it has a strong affinity for the opioid receptor. Last, there's naltrexone, also approved for alcohol use disorder. It's a full antagonist with a strong affinity. And it comes both in a PO formulation that's usually taken daily, or IM form that's a monthly injection called Vivitrol. Buprenorphine comes in a whole bunch of different formulations. Some are approved for opioid use disorder, and there are several for pain. I'm going to mostly be focusing on the sublingual and buccal formulations because we see them most often. Many of these have naloxone as part, kind of co-formulated with the buprenorphine. And the reason for that is as a deterrent to injection misuse. The naloxone is not absorbed sublingually or buccally, but could precipitate withdrawal if it's injected. And just as a side note, it's permissible to prescribe buprenorphine off-label for pain. So like Suboxone, the FDA approved medication for opioid use disorder, you could use for pain, but you cannot use the 3 types that are approved for pain off label for opioid use disorder. FDA does not allow that. So just a side note. So our hub and spoke model has been very successful at getting MOUD to people with people who need it. A hub is kind of a high intensity outpatient treatment program. They can prescribe methadone or buprenorphine. They have the ability to see patients on a daily basis, and they have a multidisciplinary team. Spokes are usually out of primary care clinics. There are about 75 in Vermont. And there's usually 1 RN, 1 mental health counselor per 100 patients. And they usually prescribe buprenorphine, sometimes naltrexone, but primarily buprenorphine. There are over 9,000 patients as of this month who are receiving MOUD through our hub and spoke system. And that makes about 1.5% of the Vermont population who is on some form of MOUD. And this model has been very successful. There are no longer wait times in Vermont to access care. So I'm going to start with a case that's actually from a couple of months ago when I was on wards, loosely based on reality, but I hope there will be some learning in it for you. So this is a 54-year-old patient, male patient with a history of opioid use disorder. He's been in sustained remission on buprenorphine naloxone, 12 milligrams daily. And he presented with a painful bullous rash involving all 4 of his extremities. He states that it started 4 or 5 days prior. It sounds like it was palpable purpura with some itching, some burning sensation, and arthralgias, myalgias, and it progressed to these hemorrhagic bullae. And his pain, he rates 9 out of 10 now, and he's developed difficulty walking, difficulty sleeping. He says he has been abstinent from drug use for 3 years on MOUD with Suboxone, and he last took his dose of Suboxone this morning, the day you are seeing him. And the picture on the right is somewhat similar to what my patient's legs look like. They were very edematous. He had these painful looking hemorrhagic bullae, and it actually appeared that he also had superimposed impetigo. So he clearly looked like he was in pain. And so, you know, our diagnostic wheels are spinning. We're thinking about what we could do to work this patient up, but at the same time, he's in front of us. He's in distress, he's in acute pain, and we have to decide how to manage his pain in this patient. So if you're like me, you might look for some guidelines, for some help on the right thing to do. And what you will find is that there is a quagmire of expert opinion and no strong consensus, which makes it difficult. So if you're unsure how you'd provide analgesia to this patient, you aren't alone. It's no wonder. There's a lot of opinion and kind of scarce evidence. So some things you may have read or come across are things like splitting the buprenorphine up in every 6 hours or so, supplementing with extra buprenorphine doses. Some people will continue buprenorphine, add short-acting opioids, stop the buprenorphine, use full agonists, and reinduce later. Other guidelines say to stop buprenorphine, start something like methadone, add short-acting opioids, reinduce later. So it's complicated and it's difficult to know what the right thing to do is. I hope I can give you perhaps a framework to go on. So this is a report from the Agency of Healthcare Research and Quality from back in April. It was a report to Congress. They were trying to inform pain management strategies in Medicare patients with substance use disorder. And they reviewed the evidence for acute pain management in patients with opioid use disorder. And they came to the conclusion that evidence on the treatment of acute pain in patients with opioid use disorder is insufficient to guide policy or clinical action at this time. However, strategies that involve continuing meds for opioid use disorder warrants further research. So I'm hoping that I can show you perhaps a framework by understanding some misconceptions about acute pain in people with substance use disorders. We can review the available data together, although it is limited. And I think perhaps most importantly, we're going to talk about some of the nitty-gritty about the pharmacology of buprenorphine, because that will help you prescribe both for pain and managing opioid use disorder. So some common misconceptions, misperceptions that I will kind of cover through this talk are first, that continuing daily MOUD with methadone or bup will provide analgesia. Second, that using full opioid agonist for acute pain will be a trigger for return to drug use for patients with substance use disorder. 3, that buprenorphine will block the analgesic effect of full opioid agonists. And 4, that you need an X waiver to prescribe buprenorphine for opioid use disorder in the hospital. We're going to do a bit of a deep dive on how buprenorphine works, the pharmacology of buprenorphine. First, I'm going to focus on bup as a partial agonist. And that means basically that the agonist effect at the mu opioid receptor is less pronounced than with a full agonist like morphine or heroin or fentanyl. If you look at the chart on the left, on the x-axis, you'll see logarithmic kind of dose increases. On the y-axis are the percent of the mu opioid receptors that are kind of the mu opioid receptor response. And you will see that with increasing doses of fentanyl or morphine, you can expect an almost 100% opioid receptor response. However, in contrast, buprenorphine, even at higher doses, reaches sort of a plateau phase, which is sometimes referred to as the ceiling effect. And this has a lot of benefits. For example, the ceiling effect with buprenorphine has been demonstrated multiple times for respiratory depression. So it causes less respiratory depression, even at high doses, compared to full agonists. So in that way, it has a favorable safety profile. It also has less psychomotor and cognitive effects compared to full agonists. However, and this is a part that I think is poorly understood, we have not established that there is an analgesic ceiling effect for buprenorphine. So some animal studies show sort of a bell-shaped analgesic dose response curve, but this has never been demonstrated in humans. And there was a systematic review looking at buprenorphine for acute pain management, not necessarily in people with opioid use disorder, but just in general. And it found 24 controlled trials, 23 of which showed that buprenorphine was equivalent or superior in terms of analgesia compared with full agonists. So my takeaways are that bup has a favorable safety profile compared to full agonists. It's probably better for analgesia than we commonly give it credit for, at least in chronic pain settings. And I think clinically, it's sort of an appealing medication for patients who may have chronic pain and have other reasons to have hypercarbia. So for example, a patient with OSA or COPD and chronic pain, perhaps this might be a slightly safer medication than a full agonist. Another point I want to bring up is that continuing someone's daily buprenorphine dose is not going to provide significant analgesia. And so I'll bring your attention to the graph there. Along the x-axis, we have time in hours, and the y-axis, plasma concentration of buprenorphine and its metabolite norbuprenorphine. And what you'll see is that the serum or the plasma concentration peaks quickly within about an hour and then rapidly declines over the course of 6 to 8 hours, and then stays at a very low serum level for upwards of 24 hours. The mechanism behind this is kind of the two-phase elimination that buprenorphine goes through. There's the alpha phase, that's when it's distributing through the plasma, and the half-life of that phase is about 3 hours. And this is where you really see the best analgesic effect of buprenorphine, when that plasma concentration is high. So around 6 to 8 hours. So the dosing for analgesia ideally is every 6 to 8 hours. Then there's the beta phase, or the terminal phase, which represents distribution in the tissues. And that half-life can be up to almost 40 hours in the sublingual form. And you have a very low plasma level throughout that stage. And this is really where buprenorphine is good for treating opioid use disorder, because that low plasma level will prevent withdrawal and reduces opioid craving, and can be dosed infrequently, like every 24 hours. Also, buprenorphine has a very strong mu-opioid receptor affinity. It slowly dissociates from that receptor. So this means for patients on buprenorphine, adding full opioid agonists may theoretically have less analgesic effect because of that strong affinity of the buprenorphine. However, experimental animal models show that buprenorphine, with the addition of full agonists, resulted in additive or synergistic effects. So it's not that you can't provide analgesia if you continue buprenorphine. It may mean that it may require slightly higher doses of full opioid agonists to get the analgesia result you're looking for. And this is because buprenorphine binds competitively. And then to talk about, I'm going to talk about the evidence for medications for opioid use disorder, particularly buprenorphine and methadone, and acute pain management, which, as I mentioned before, is rather limited. So I found in the Journal of General Internal Medicine from 2 years ago, there was a systematic review looking at this topic, and there were 12 observational studies identified, no randomized controlled trials. 3 of the studies did have a control group. Of those 3, 2 showed that buprenorphine or methadone post-operatively continued in a post-op period, reduced the need for additional opioid analgesics. However, 1 of those 3 studies showed that patients continued on their MOUD, needed higher opioid doses post-op. However, they ended up having similar pain control outcomes regardless. The overall conclusion from these authors was that the quality of evidence was low. And their kind of summary was that, quote, the best available evidence suggests that continuing methadone and buprenorphine during episodes of acute pain is preferable to discontinuing these medications. But of course, more research is needed. You know, we all know from practicing medicine that acute pain management can have challenges, particularly in patients with substance use disorder. It may be difficult regardless of whether you hold your buprenorphine for your patient. We know that a majority, 2 out of 3 patients who have opioid use disorder also have concurrent chronic pain issues. Patients on methadone and buprenorphine have less pain tolerance than matched controls. There are also issues of tolerance, potentially hyperalgesia, and it may be that there's a higher analgesic requirement regardless of what you do. So Just to get back to our case, we had our 50-year-old male with a history of opioid use disorder in remission on Suboxone, and he's coming in with this terribly painful bullous rash on his extremities. When you examine him, he looks uncomfortable, and he's ultimately diagnosed with a leukocytoclastic vasculitis and superimposed impetigo. And in the interim, you're tasked with managing his pain, of course. I'm going to outline some potential approaches. There is no absolute one correct answer, but I'm going to show you some approaches that I think are best supported by the evidence, and hopefully give you some pearls you can use in your practice. So for this patient and for all patients on MOUD and acute pain, there are some things you want to consider. First and foremost, you want to talk openly with your patient about pain management and about their social history. So informed consent. The decision to, first of all, acute pain and the prospect of changing MOUD for patients is often very anxiety provoking and can be destabilizing. And patients may have strong opinions about whether they want their buprenorphine changed or not. And so it's important to understand where they're coming from and have an informed consent discussion. For all patients, you should check your state's prescription drug monitoring program just to confirm they actually have an active prescription, to understand their dose. If they're on methadone, at least for opioid use disorder, it won't be in the drug monitoring program. So you would have to call the clinic and confirm dosing. You want to ask the patient when they last took their dose, because that'll help inform kind of your treatment plan for them. And then, just like any other patient, regardless of their substance use history, we always think about non-opioid strategies. So, acetaminophen, preferably scheduled if possible, NSAIDs unless there's a contraindication. If there's a neuropathic pain, pregabalin or gabapentin. Regional anesthesia, nerve blocks might be a useful tool, or for refractory pain, or if there's a contraindication to opioids, perhaps ketamine. So use all the tools in your toolbox. So for this particular patient, this is sort of the approach I took, and an approach I think is reasonable for many patients who are hospitalized with acute pain. So that is to just continue the buprenorphine. That is, if non-opioid agents are not adequate to treat pain, then you would consider potentially adding opioids. One thing you could do as well is split the buprenorphine dose that the patient takes at home to maximize its analgesic properties. So that would mean for this patient, he was on 12 milligrams daily. You could split it, to 4 milligrams Q8 hours, and that would give a very kind of modest analgesic effect. You just have to remember, for these patients, it likely won't be adequate because you're just kind of keeping them on their baseline dose anyway. So if you're going to use opioids for analgesia, you'll probably need to add something else. But if they had mild pain, perhaps that with some non-opioid agents might be enough to get them through. But for more severe pain, and if your patient's amenable, you could start a short-acting opioid. I would recommend something with a strong receptor affinity, such as hydromorphone, morphine, or even fentanyl, and just be cognizant of you may need to use a higher dose to overcome that strong receptor affinity of the buprenorphine. So, for example, for this patient, in addition to non-opioid modalities like Tylenol, and he actually took gabapentin at home, I split his bup dose, and then we did 6 to 8 milligrams of hydromorphone every 4 hours as needed, and that proved to be adequate analgesia for him. And then I like to speak upfront with my patients as openly as possible. I like to reassure them that their opioid use disorder, their history is not deterrent to adequate pain management, that we will manage their pain. And I also set the expectation early that once pain is improving and controlled, that we will taper the opioids. So a second approach that is also not wrong, but in my opinion is perhaps a bit more complicated, is stopping the buprenorphine. As this is kind of something that could be considered in very severe or refractory pain. So if you have a patient, you've continued them on buprenorphine, you've added opioids, it's not working, and they're really in kind of acute pain, this is sort of when I would consider this. Additionally, for patients with elective surgeries that are expected to cause severe post-op pain, some surgical teams and anesthesiologists will hold their medication 3 to 5 days prior to the surgery. So one of the things that you have to keep in mind is that if you do hold the buprenorphine, it will slowly wear off over the course of 24, 48, 72 hours. And your patient may experience sedation and theoretically, there could be a risk for some respiratory depression as that wears off and the full agonists take effect. So you may need to slowly down titrate as the buprenorphine wears off. I will say the American Society of Addiction Medicine has put out some guidelines, and they aren't clear cut in terms of whether or not to stop the bup. So they say for severe acute pain, discontinuing buprenorphine is advisable. However, there are data to suggest that discontinuing bup is unnecessary and that adequate analgesia may be possible by simply adding non-narcotic and narcotic analgesics to the patient's baseline buprenorphine dose. So a brief word about kind of perioperative pain management on your patients who take buprenorphine. There really is not a consensus, and the guidelines I've come across vary quite a bit. So anything from holding the bup for 3 to 5 days before an elective procedure, to continuing it through the procedure, to stopping and starting a long-acting opioid in the interim. So it's really all over the board. The example I've included here is from the 2019 Pain and Addiction Interdisciplinary Network, who recommend continuing buprenorphine, adding non-opioids and opioids as needed. And then, as I sort of discussed prior, if that is inadequate for analgesia, you could consider decreasing the buprenorphine dose to take advantage of more opioid receptor availability in the central nervous system. And then they recommend discharging the patient, continuing them on their buprenorphine basically when they leave. The two things I really like is that they include, the recommendation to discuss with the patient's patient addiction treatment provider, and to engage the patient in discussions around their analgesia. So I think, with all of this said, it is important to take this on a case-by-case basis and weigh the risk and benefit for the patient you're caring for. So weigh the risk and benefit of stopping the buprenorphine. I think the risks are pretty clear. So, stopping buprenorphine for 3 to 5 days before a surgery will put your patient in withdrawal first. It's stressful and can be destabilizing for them. Their tolerance may be reduced in that interim, and that opens a window of risk where if there is return to use, there's a much higher risk of overdose if someone's tolerance has been lowered. So I always say to respect tolerance and proceed with caution if that's a route you're taking. There is limited evidence that stopping buprenorphine will allow you to provide superior pain control. If you stop it, it will require a period for reinduction or restarting buprenorphine, and that means the patient would need to go through some period of withdrawal, most likely. And it's not really practical for most of the patients we're admitting for the emergency rooms, for example. So if they're in acute pain, they already took their buprenorphine that morning, it's like that has already occurred. So the benefits, of course, are that if there's no buprenorphine in the system, we're more confident that we can provide analgesia with full opioid agonists. And it also might be practical if it's like a planned surgery. It can be discussed between the primary care provider, the addiction provider, and the surgical team and anesthesia. So for something that's expected to cause severe pain, it might be something you could consider. And I think most importantly, we just have to talk to our patients and see, explain the risk and benefit and see if they have a strong opinion one way or another. So on buprenorphine reinitiation, also sometimes called induction, I'm not going to dive into this too much, but I'll briefly mention it because it will come up if your patient had stopped taking buprenorphine, or I've had patients who declined to take their buprenorphine in the hospital. And so, there may come a time where you need to reinduce your patient on buprenorphine. So some things you need to be aware of: their acute pain should be improved or resolved, ideally. The patient needs to be in mild to moderate withdrawal. You can use the COW score, clinical opioid withdrawal score. It should be around 8 to 12. So that means for sure, acting opioids for heroin, for example, or morphine, the patient should be abstinent for about 12 hours or so to be in mild to moderate withdrawal. For longer acting opioids, such as extended release morphine, at least 24 hours should pass. With methadone, even longer, so that can be tricky. You will start with a sort of a test dose of buprenorphine, 2 to 4 milligrams, just to make sure you don't precipitate withdrawal. The risk of adding a partial agonist to someone who has a full opioid agonist in their system is that you will bring them down from that high level on the opioid effect curve down to a lower level, and that can precipitate some withdrawal. But if you ensure they are already withdrawing and you give them a test dose, there's a low likelihood that will happen. You will reassess their withdrawal score, quantify their withdrawal 1 to 2 hours later, and then you can redose 2 to 4 milligrams and you can repeat until their symptoms are controlled, and hold for sedation, of course. Here's one example of a hospital protocol for initiating buprenorphine. This is out of UCSF. I think it's very practical and easy to follow. There are other protocols. SAMHSA has a really nice outpatient protocol that I like and can be adapted for inpatient as well. So the main points are: 1, your patient's pain needs to be improved. 2, they need to consent to initiating buprenorphine. 3, they should be in mild to moderate withdrawal. And 4, give them a test dose. And usually the therapeutic range for treating opioid use disorder with buprenorphine is around 8 to 16 milligrams, although some patients will be on a higher dose, up to 24 milligrams. So my take-home points for you on this buprenorphine section are that most patients should be continued on buprenorphine during acute pain episodes, including the post-operative period. Second, splitting the buprenorphine dose every 6 to 8 hours will maximize its analgesic effect, but is unlikely to be adequate for pain control if someone's pain is moderate to severe, but maybe enough if it's mild. And then 3, for patients on buprenorphine, adding a full opioid agonist can provide effective analgesia, although you may need a higher dose to reach that level. Okay, for the next part of my talk, I am going to briefly go through some scenarios and try to give you a few pearls that you can use in your practice. Each of these could probably be a lecture on their own, but we don't have that much time. So I'm just going to give you a couple of points on each scenario. So the first is on people who are on methadone for opioid use disorder and have acute pain. How do you manage that? So of course we verify the methadone dose by calling their clinic. It's very similar to buprenorphine, actually. Methadone can be split to TID dosing to maximize its analgesic effect. Usually Q8 hours is how we dose that. But again, for your patient who is chronically on methadone, has been on a stable dose for a while, that's unlikely to provide a lot of analgesia, or if any at all. We need to be more cautious about additive effects of other opioids. So because methadone's a full agonist, if you add other opioids on top, there is a theoretical risk of sedation and respiratory depression. Methadone on its own is a risk factor for sleep apnea, in fact. So that is something we need to be cognizant of. However, this is tempered by the presence of cross tolerance in your patient. So I think you don't really need to be too worried about this, but it's something you should just be aware of when you're dose titrating. And then we know patients on methadone for opioid use disorder can be treated with opioid analgesics for post-op pain without increased risk of return to drug use. So this is from a study from the 80s, where they looked at a group of patients on methadone who had acute pain and were treated with opioid analgesics, and they compared it to a group of patients on methadone for opioid use disorder who did not have an acute pain episode, and they followed them for 20 months. And what they found was there were no differences in indicators of return to drug use or relapse. And then perhaps one of the most complex issues, I guess, with acute severe pain is for patients who are on naltrexone. So naltrexone could be either for opioid use disorder or alcohol use disorder. So as you know, it's an antagonist. It's very effective. This is a study from 1981. It's kind of a crazy study. They took a group of patients with opioid use disorder in remission. They gave them 100 milligrams of PO naltrexone, and then they injected them with 25 milligrams of IV heroin. And they followed them for 3 days and looked at the antagonist effect of the naltrexone. And what they found was that it was extremely effective, and even 72 hours out from that dose of naltrexone, almost half of the opioid receptors were blocked. So this has implications, obviously, for acute pain management. PO naltrexone, if it's a pre-op situation and you have time to plan around an elective procedure, you want to hold it for at least 3 days. And just keep in mind, these patients are essentially opioid naive. So they will not have a tolerance off the bat. For the IM naltrexone or Vivitrol, that's dosed every 30 days. It has a peak plasma concentration at about 3 days, which declines after 2 weeks. But if you can, you want to delay a surgery for 1 month after the last dose. And then for those patients who come in with some kind of emergent pain, this is a situation where I would consult anesthesia. So ideally, you will use opioid sparing strategies. So non-opioids, regional anesthesia. And if opioids are required, it needs to be done in an ICU setting with the ability to intubate someone, because these patients are going to require really high dose, likely fentanyl. Animal models show that you need like 6 to 20 times the opioid dose you would under normal circumstances. So it's high risk. And as the naltrexone wears off and you have opioids in the system, there's high risk of respiratory depression. And then what about our patients who have perhaps active opioid use disorder and acute pain? This is something we see very commonly, I would say, on the wards. As we know, tolerance is present, and we have probably all experienced this, that there's an unfortunate association between untreated pain and patients leaving against medical advice. So in terms of starting out opioids, if they're needed for analgesia, typically a short-acting opioid scheduled with some hold parameters for sedation. Expect to use higher doses because of tolerance, and use PO when possible over IV. All patients with opioid use disorder should be offered MOUD. It's sort of analogous to having a patient, say, with heart failure with reduced ejection fraction. You're going to offer them guideline-directed medical therapy. And in the same way, you should be offering MOUD to your patients with opioid use disorder. It's a gold standard, and it reduces mortality. And then I cannot get through a talk without at least mentioning some harm reduction principles. So for patients who are using injection drugs, you should consider PrEP, pre-exposure prophylaxis for HIV. This is actually a grade A USPSTF recommendation for patients who inject drugs and share injection equipment and or engage in high-risk sexual activity. And then be familiar with your local syringe service programs. And if your patient is unaware of how to access those things, you should provide that information. And then everybody, I kind of think everybody should have naloxone and training on how to recognize and treat opioid overdose. And the last scenario are your patients who are in remission from opioid use disorder and who are not on a medication for opioid use disorder. So these patients have typically worked really hard to get where they are. They've beat the odds, and of course we want to support them in their efforts, and we don't want to do any harm. I will say that often it gives us pause to start opioids for acute pain in these patients, of course. But there are studies that suggest that the risk of return to drug use may actually be higher from inadequately treated pain compared to the use of opioid analgesics. Ultimately, it's a discussion between you and your patient, and a dialogue. Some patients feel very strongly that they don't want opioids in their pain management plan, and we should support them as best we can, of course, in those decisions. So multimodal pain strategy, non-opioid strategies whenever possible. And of course, these patients won't have a tolerance. Discharge planning, extremely important. Talk about your discharge plan early with your patient, set the expectation early that opioids will be tapered once pain is improved or controlled. Ideally, your patient, when they go home, will go home on their MOUD regimen that they were on before they discharged. And if they do need opioid on discharge, really important to have a warm handoff and warm discussion with their outpatient team, and preferably a short course of opioid. Ensure the patient has follow-up with their addiction treatment team, and ensure they have a bridge, say, of buprenorphine to get them through to that appointment if they're on buprenorphine. Methadone, we aren't, of course, allowed to bridge because of prescribing laws, so we can't do that outpatient. How am I doing on time? Out of time. Just a quick plug.
Go ahead. I was just going to say that we're out of time. That's okay.
So just a quick plug to go online and apply for your BUP waiver. It takes 5 minutes through the SAMHSA website. You no longer need to do the 8 hours of training. This will allow you to prescribe BUP when your patients leave the hospital. And I went a little over, I'm sorry.
No, that's okay. And I apologize for the interruption that we had earlier. Elly, thank you so much. Really appreciate it. That was really, really helpful, really informative. And maybe I'll ask, there's one question in the chat that I think we do have time for, if you're okay with that.
Go for it.
So somebody asked whether or not, of other ways of assessing pain in these patients, apart from self-reporting, and kind of in your experience, are the patients who have substance use disorder, are they more or less reliable in reporting their pain?
think patients are more likely to have pain and have difficulty controlling their pain. I don't know about the reporting the pain part. I do feel like the 1 to 10 score is not as useful. I ask that sometimes, but I also want to know about like their function. So are they able to eat? Are they able to sleep? Are they able to work with physical therapy? And I find it useful also to set the expectation that maybe our pain goal, like it's not realistic for it to be a 0, but perhaps our pain goal can be getting sleep at night, you know, functioning with IADLs or ADLs, working with PT. So sometimes I frame it that way.
Absolutely. Thank you so, so much. I really appreciate
Thank
it.
you.
All right. And for everybody else, our next talk starts in just a couple of minutes, and there's